SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Hello, my name is Scott Acuno, Chief Medical Officer at SARC, and just want to highlight our next episode, SARC 38, where we have a very engaging conversation with Dr. D'Amato, who is a medical oncologist at University of Miami, and two pathologists, Dr. Rosenberg and Dr. Pinto. Dr. Rosenberg is a bone and soft tissue expert, pathologist, and Dr. Pinto is an expert in gynecological sarcomas. And in this podcast, we actually have a great discussion of how women with gynecological uterine sarcomas are managed from the medical oncology standpoint, as well as the pathology aspect when we have two experts in uterine sarcoma and soft tissue sarcoma. So we hope that you enjoy the podcast. It's very interesting how this group down at University of Miami, Sylvester Cancer Institute, is able to coordinate and to collaborate from the pathology and the medical oncology standpoint. So hopefully you enjoy the podcast. Thank you. Welcome to SARC Talk, episode 38. My name is Scott Acuno, a medical oncologist at Mayo Clinic and Chief Medical Officer at SARC. At SARC Talk, we interview interesting people who are connected to sarcoma, where we can all share and spread the knowledge about sarcoma. All episodes are posted on our website, Spotify, and YouTube, SARC channel, or wherever podcasts are available. Please subscribe and submit comments because we do follow. Today, our guests are Dr. Gina D'Amato. She is a professor of medicine and clinical sarcoma lead of oncology. She's assistant director of the clinical research and administrator of the Horowitz Solitary Fibrous Tumor Institute Fund at Sylvester Comprehensive Cancer Center at the University of Miami. Dr. D'Amato leads our monthly sarcoma multidisciplinary tumor board, and she leads that quite valiantly. So if you want to visit with her, that she's always there. Interesting cases that she does moderate. She's joined today by two pathologists over at University of Miami. We're fortunate to have Dr. Andrew Rosenberg, who is the director of anatomical pathology at Miami, and he is the director of the bone and soft tissue section there. We also have Dr. Andre Pinto, who is an associate professor of DLMP. He is a pathology residency director, and he is a director of the gynecology pathology section, and he's also head of the fellowship for breast and gynecology pathology. And today we're fortunate to have our broad discussion about uterine sarcomas. And why is that important? Uterine sarcomas are sarcomas, but they are also treated and managed by two different pathology groups, two different medical oncology groups. And I think this is something that as sarcoma providers that we see, we sometimes get torn between the two different theories of how to treat and manage and diagnose sarcomas. So with that, we're quite happy about that. And maybe Gina, Dr. D'Amato, maybe you can start with your just broad topic thinking about is, what are some general facts about uterine sarcoma, kind of the gestalt of how we kind of start to see individuals with uterine sarcomas, and then we'll start asking our pathologists a little bit more about the details. So Gina?
So, uterine sarcomas, basically sarcomas can start out anywhere in the body. And, if it starts out in the uterus, it just so happens to start there. They're different than endometrial carcinomas because it's not from the endometrial cells, it's from the connective tissue that support the structure. So either the most common is leiomyosarcoma, the smooth muscle portion. You can have endometrial stromal sarcoma, the second most common. And then after that, you have more rare types of tumors such as, pleomorphic undifferentiated or rhabdomyosarcoma or pecoma, for example. So it's difficult to treat because, it's kind of controversial, so to speak, is that should these uterine sarcomas be treated by sarcoma medical oncologists, or should they be treated by gynecologist oncologists? And so we have to work together with both colleagues need to work together to be able to properly treat these patients.
Yeah, absolutely. And as people, our audience is listening here, is that there are centers where it's pretty defined which medical oncology team would start to see these individuals. When you start to go to these bigger places like Memorial Sloan Kettering University of Miami or other major sarcoma centers, they have it's a division of who sees them. At our institution, we tend to see them all in the adult sarcoma group, and all the med gynae will definitely get them across to our thing. We're very fortunate where I work. It's the same hallway, so if they happen to go in the wrong place, it just come across. Maybe from Dr. Pinto and Dr. Rosenberg standpoint, how do you as pathologists start to see a case, and how do you decide, is it going to go to the gynecology pathology group or the bone and soft tissue if the diagnosis is a sarcoma and it happens to start in the uterus?
I can just briefly say it. We don't really have a formal rule because we work together in most of these challenging cases. But as a general approach, if the patient is coming here to see Dr. D'Amato or the medical oncologists, that tends to go to Dr. Rosenberg. And if the patient is coming here to see a oncologist by the group that I work with, because this gets presented at tumor boards and the sessions, usually comes to me. But quite often we share cases among each other.
Yeah, I could add this from my perspective. As true in most organ systems, the neoplasms that arise within them recapitulate the normal cell populations that are usually present in the organ. And what I see with regards to uterine sarcomas is that a significant number recapitulate mesenchymal cells or types of mesenchymal cells that are in the uterus, but not elsewhere in the body. And as I view myself as somebody, quotes, a sarcoma pathologist, it usually relates to sarcomas that are occurring in soft tissues or some viscera. But when I am confronted with a sarcoma arising in the uterus that I suspect is recapitulating, say, an endometrial stromal cell, and I'm not seeing that on a daily basis in my practice because I'm looking at sarcomas arising elsewhere, that's when I defer to my GYN pathology colleagues who have more focused experience in those kinds of tumors. And that's when I would use my judgment to say Dr. Pinto would be the most appropriate person to assess this tumor rather than, say, myself.
You bring up you both bring up a very important part, is that it's collaboration. And that's where the patient wins no matter what. Because in reality, we all know our blind spots, and I don't want to say blind spots in a bad sense, but we know that everything that we do, that we have expertise in other parts of our practices, and that way we will leverage it. And people that are listening have to really understand that when you go to University of Miami, they work together, the pathologists. So if it happens to be a leiomyosarcoma that could occur in the arm, and it's the same thing that can occur in the uterus, they're going to collaborate if appropriate and kind of make sure it's the right diagnosis.
Correct.
Agree.
One of the things as a medical oncologist in our world is there are certain things that I like to see in a primary tumor diagnosis of, let's say, leiomyosarcoma. And I know that sometimes if it's read out by a bone and soft tissue pathologist, Dr. Rosenberg, it might be different than what Dr. Pinto might read out in a uterine leiomyosarcoma. So some institutions, will acquiesce, but how does the University of Miami kind of look at that and say how do you work through that? Because as a clinician, we have certain ideas, and I'll ask Dr. D'Amato what decision she makes based on both of your pathology reports of the same slide.
Yeah, I think that you brought up a very good point, because this is quite often something that Dr. Rosenberg I would say disagree, but we have different opinions on.
Philosophy.
That's the whole point of all, I guess, this discussion here, is that for us in the gynecology, like mesenchymal pathology of the uterus, grading leiomyosarcomas is not reliable. We do not use the conventional grading system that is applied to most sarcomas to uterine leiomyosarcomas, because most data don't show any difference on a high, quote unquote, high grade, morphologically high grade leiomyosarcoma versus low grade. On the contrary, you might have the ones that look very bland and metastasize all over, while the ones that are necrotic, pleomorphic, and full of mitosis, they actually behave well. So the recommendation that is in general approached by most gynecologic pathologists is don't use a histologic grade, because that has not been validated in studies. But Dr. Rosenberg, I think he has a different opinion on that.
Dr. Rosenberg.
Yeah, so I would like to start out that I think a lot of the important aspects of our reports contain the same information, that we give a specific, precise classification and subclassification of the tumor. When appropriate, we are assessing the margin status, whether or not there's vascular invasion, and other attributes of the tumor. I think the one area that we do differ is what Andre was mentioning. He will not provide a grade, just use a diagnosis, leiomyosarcoma, maybe subtype if it is of a specific subtype, where I will give a grade. And my rationale for giving a grade is, in my experience in working with medical oncologists, they usually want to get an idea of how aggressive does it seem to look like to use as a piece of information to integrate into their treatment recommendations. And in a minute, maybe Dr. D'Amato can comment on, is she looking for that kind of information? If so, why? How is she integrating that in to her treatment strategization? Because I feel in the majority of mesenchymal tumors in which there is stratification grading, to me, it's common sense that even though I think that literature is a little controversial, that there's likely, I think, an association between grade and the biological potential of the neoplasm.
Well, this is a great opportunity. Gina, maybe your thoughts as a clinician trying to get people on clinical trials and making recommendations for therapy. Go ahead.
So when we see a patient, the majority of the times for other sarcomas, if it starts out in the extremity, sometimes we do get lucky and we can see the patient before they've had resection. With uterine leiomyosarcoma in particular, the majority of the time, patient presents with presumed fibroids, undergoes a hysterectomy, and there's where you find the leiomyosarcoma. And when we're trying to recommend adjuvant therapy, we really need to understand the prognosis. So if I were to go, some of the prognostic factors that are important for all sarcomas is size and grade. Grade across the board for all sarcomas is the most important prognostic factor. And if I were to use just that, and then of course the size. And so in the staging is also very controversial because do you use the FIGO stage or do you use just the soft tissue sarcoma stage? But we're just talking about the grade itself. If I were to try to talk to the patient about prognostic factors and what can I do, can I recommend adjuvant therapy, or are you eligible for a clinical trial, say with adjuvant chemotherapy? And I were to use, I use the Memorial Sloan Kettering nomogram. They have one for uterine sarcoma after resection. So that's age, size, grade, cervical involvement, Mets local regional, and mitotic index. So I really need that information for me to plug that into the nomogram in order for me to talk to the patient about their prognosis and potential adjuvant therapy. I also like to have estrogen status as well. And that is not often reported unless requested. There's been some, underwhelming studies of hormonal therapy in uterine leiomyosarcoma. But, and there are some studies to allude to his prognostic, it has some prognostic significance. It's not as important as, say, the grade for me, but it's a nice to have.
You're correct. And, as a clinician, Dr. D'Amato talked about the FIGO staging. And Dr. Pinto shook his head. He knows exactly correct, because in the gynae world, everything is based on the FIGO scoring. And there have been people who've looked at the FIGO scoring stage and did a crosswalk with the same thing put into a bone, soft tissue one, and they line pretty good in a lot of them, but there are nuances behind it all. So from our standpoint, you can have a huge leiomyosarcoma of the uterus and it's a stage 1 because we don't grade it. Whereas in our world, if it's in an extremity, it's going to be a stage 3. So you can just imagine the differences between it. And, part of what we are trying to share during this podcast is we can all play in the same sandbox. Where do you guys see us going? Because there's some, I don't say deep entrenched thoughts on this, because I don't know how we're going to, how do you both as bone and soft tissue and gynecology pathologists help work on that? And how does the society and pathology work to resolve it? Or is this something that's never going to be resolved?
Well, to make things worse, in GYN, we also have the AJCC, which is different than FIGO. So we always provide 2 stages, which sometimes are very different. Like we have tumors that are, for example, involving the lymph nodes that upstage not necessarily sarcoma, but in general. So it can have a uterine cancer that is a stage 1 and 1, and then for FIGO makes it 3. And for AJCC versus FIGO, then these patients go see our colleagues from medical oncology, come back with a different grade. So it's like, and the patients get what's going on. But unfortunately, I think that's a result of this kind of subspecialization that it's looking at their own tumors without this integration. Hopefully at one point, we're going to have a formal single staging system for all the sarcomas, but we're not there yet, far from being there yet.
Exactly. Dr. D'Amato suggested that for uterine tumors, we like to have estrogen and progesterone in it. Are there any other typical molecular things or immunohistochemical things that you typically would do, let's say in a leiomyosarcoma, that we probably wouldn't be doing if it's an extremity one, Dr. Pinto?
So for decades, and still for most of the time, the diagnosis of uterine leiomyosarcoma is purely morphological, right? We can go into the details later in terms of what we use to stratify or to classify these tumors as leiomyosarcoma. But the only time that we apply, or the 2 scenarios that we apply, immunohistochemistry. The first is if the tumor is very undifferentiated or not sure if that's a leiomyosarcoma, right? Because like Dr. D'Amato said, there could be endometrial stromal tumor, could be rhabdomyosarcoma. So we used to diagnose, right, the tumor correctly in terms of having some smooth muscle differentiation. Therefore, it's probably a leiomyosarcoma. But the thing that is kind of emerging right now is that since there was a large study that came from New York, the group from Sloan Kettering a few years ago, with an algorithm to diagnose leiomyosarcomas, because we do have cases that it's a smooth muscle tumor, but you're not sure if it's benign or malignant. So they propose a molecular surrogate of IHC that could be potentially applied for the diagnosis. And we've been using in a very select, case by case kind of basis. And there are more studies supporting that approach. But again, it's still a morphologic diagnosis, but we are starting to get to a more molecular surrogate IHC for diagnostic and classification of these tumors.
But with regards to biological markers that could be used to provide prognostic information, say like PD-L1 or HER2/neu or something like that, there currently aren't any, and possibly genetic profiles could be used to help stratify patients according to prognosis. But other biomarkers, as I just mentioned, aren't being used. The markers that Dr. Pinto mentioned are those to help make a definitive diagnosis. But once the diagnosis is made, again, we lack good biomarkers for prognosis.
That's exactly correct. And I'll be remiss if I don't reiterate that one more time. To make the diagnosis is one thing. And then the second part, is there anything on the tumor that we can help Dr. D'Amato and us figure out how to treat or when to treat or what to treat? It is different. And I'll just come back because this comes up quite a bit. And we do see a lot of what we would say is smooth muscle neoplasm or stump. They're not the same, but they're stump. And we struggle with that in the clinic because we don't know how to treat those per se, because that's what the name is. So how do you as pathologists look at that to make sure that it is, as you said, benign or less malignant, and help lean us a little bit more that it's going to potentially do something different?
So I think the most I try to avoid, and I believe Dr. Rosenberg shared the same approach, this diagnose as much as I can, stump, because I know it's very comfortable for the treating field, for you guys, for the treating oncologist. It's very uncomfortable for the patient. Sometimes it's better to have a definitive, even if it's malignant, at least they know what they need, they know how to approach and to treat it, right? And this stump is this limbo, which it's this gray zone that doesn't help anyone. But I guess the first thing that we do to avoid this diagnosis is that once I'm considering calling a tumor a stump, I don't do until I go back and put much more, I sample much more the tumor, right? Because usually the sarcomas are large, or could be 10, 15, 20 centimeters. And sometimes all you require is to have one piece of tissue with necrosis to make the diagnosis. So we always oversample tumors that we're considering calling a stump. And after you did all your homework, your diligence, and the tumor falls short for the diagnosis, it looks suspicious, but it doesn't meet the criteria, which for just kind of in a nutshell, for the conventional type leiomyosarcoma, we're talking about mitotic count, which is 10, necrosis, and moderate to severe nuclear atypia. If you don't have two of the three, so if you have, for example, 8 mitosis and you have atypia, you don't fulfill the criteria, so you have to be in the middle. The message we're telling him is it's not your leiomyoma, your conventional leiomyoma that we see every day in the table. but I unfortunately cannot pull the trigger and call that leiomyosarcoma. And some, just going back to grade, some experts, not many, but like some would approach that stump as a low-grade leiomyosarcoma, saying like, okay, it is atypical, it's a low-grade malignancy, and once we make the diagnosis of leiomyosarcoma, we automatically cross to the high-grade malignancy. So that's why the grade may be like, a little wishy-washy there, because I've seen stumps being called low-grade leiomyosarcoma, but that's not the standard. So just to go back, the definition of stump is when you fall short for the diagnosis of leiomyosarcoma, but were some features to call this leiomyoma.
Dr. Rosenberg, any other thoughts from a bone and soft tissue aspect?
Well, like Dr. Pinto, I try to avoid that term as best as possible. I know my clinical colleagues just want black and white. But there is this small percentage of cases where I can't make the diagnosis of leiomyosarcoma, but I want to alert the clinicians that this patient needs more careful follow-up because of the potential, and it may be small potential, that it could metastasize. And for that reason, the patient should be followed differently than a conventional leiomyoma. And again, molecular stratification might be able to further pick out from that group those that really do or do not have the potential to metastasize.
Perfect. So Dr. D'Amato, your thoughts now, if you get a diagnosis not of a uterine fibroid, but rather a stump, and they come to see an adult sarcoma oncologist there, how do you manage that then?
I call up Dr. Rosenberg and Pinto and say, are you sure it's a son? It's difficult. What I do is for a stump, I explain to the patient, look, we're stumped. This may or may not turn into cancer. We don't know. I think we should monitor you closely. I would also do a full, assessment. Have they ever had cancer before? Do they have family history of cancer? If they do have family history of cancer, then I would refer to the genetic counselor and see, are they at higher risk? Maybe, are there any molecular features that would make me believe that this could turn into a sarcoma? And then I would offer them monitoring as a low-grade sarcoma, and I would offer them, every 6 months scans or once a year scans, depending on the age of the patient. I would offer either CT scans or, if they're a younger age, probably MRIs for less radiation, and give them the option. At minimum, we would want them to be followed with a physical exam and labs once a year. That would be minimum, but again, I would offer the patient extra scanning if they're worried or there were any high risk features.
Correct. And I think that's the message that we're hearing is both pathologists work very, very hard to get it out of the stump realm into a benign versus LMS. And because we don't know, they've really scrutinized and landed on, I can't put them in either category. I'm going to give it a stump. It's undetermined malignant potential. So we don't know, and we just follow them. And it's not a benign, but we're not quite sure, So I think that helps us out quite a bit. And we do appreciate the rigor. Once you start to see a couple things, you're going to look harder in the whole dang specimen. So there's a lot of sampling that goes on to do that. So, and this is where the pathologists work well together.
And if you have a pathologist on stump, every kind of other week, you should have a conversation with them because it should have very rare diagnosis. So
you got to get them into the other buckets. Uterine sarcomas as a whole, we typically say 3 to 5% of all uterine malignancies. We spent some time talking about the leiomyosarcoma. We hit a little bit on stump, rare, but there are some other ones as well. And Dr. D'Amato talked about the PEComa, which usually starts in the uterus, but we would like to hear a little bit about that because that has potential impact on treatment. And then there's this other group called the ESS, and you kind of brought it up as well. And we just want to make sure because these are hugely different than the pure high grade, or we don't call them graded now, uterine LMS. So maybe you can share a little bit of what a PCOMA is. And then the other part is kind of what an ESS is. And grading is important for us in the ESS realm, and hormone status is important. I'm not sure how much work is done above and beyond to confirm a PCOMA diagnosis, but I'd like to hear your thoughts because PCOMAs can occur outside of the uterus as well. So Dr. Pinto, we'll start with you.
Sure. Yeah. So after leiomyosarcomas, so leiomyosarcomas in an average, about half to a little bit more than half of all the uterine sarcomas, right? So in general, we're gonna, everybody as a pathologist will diagnose a leiomyosarcoma. And then endometrial stromal tumors come second, which we call them tumors because they can be nodule and it can be endometrial stromal sarcoma. And even more, the sarcomas, this is one, the grade is extremely important for the endometrial stromal sarcoma because these are two different malignancies. The low grades, they have different morphology, different immunohistochemical profile, different molecular signatures from the high, like almost if they were different malignancies. But they arise from endometrial stromal cells, which is a normal constituent of the layer, the endometrial mucosa. And there is certain morphologic criteria for the diagnosis. And in general, for the low-grade endometrial stromal sarcoma, it's a morphologic diagnosis. We do a morphological and immunohistochemical. You don't require molecular sequencing. For the high grade, it's because now we're learning more from these tumors, and the World Health Classification Organization kind of subtype them based on the underlying molecular either fusion or mutation. It's, if you work in an academic center, then it will be highly recommended that you send those tumors for sequencing, because the formerly called undifferentiated uterine sarcoma, which was part of this endometrial stromal neoplasms, now it's like a diagnosis of exclusion, only when you rule out every single molecular category. So that's why we're kind of evolving, and I'll defer to Dr. Rosenberg in a second, because a lot of the sarcoma diagnosis and the soft tissue require next generation sequencing or other types of molecular studies. And just to kind of, just because you asked for the PCOMA, just in a nutshell, PCOMAs are a tumor that, in contrast to like leiomyosarcoma that arise from the myometrial cells, endometrial stromal sarcomas that arise from endometrial stromal cells, PCOMAs, they are thought to arise what we call the perivascular epithelioid cells, which are cells that are possibly around the blood vessels, and it can occur anywhere in the body and also in the uterus. And the challenge with the PCOMA is that they also share a lot of morphologic and immunohistochemical similarities with leiomyosarcoma. So I have seen countless cases that one institution calls PCOMA and we call leiomyosarcoma and vice versa. So it doesn't get better, right? Like, there's so many nuances, but yeah, so that's another tumor that I asked Dr. Rosenberg if he also shared this approach that we require in order to make the diagnosis, unless it's like very immunohistochemically distinct, we always tend to send those for next generation sequencing to have that, which in the PCOMA is the TSC or TFE3 alterations.
Dr. Rosenberg, thoughts?
Yeah, I agree with what everything that Dr. Pinto said with regards to the importance of NGS and really precisely subclassifying the sarcomas, being able to identify some of them as endometrial stromal in phenotype. NGS is also identified within the uterus, sarcomas that also can occur within the musculoskeletal system. And so it's it has helped change the landscape significantly with regards to both nomenclature used for the type of tumor and its associated biological behavior.
So, Dr. D'Amato, as you're approaching somebody with an ESS or a PCOMA, what are different thoughts in your mind for drug treatments and systemic treatments, that how important it is to make those distinctions?
So it's extremely important. For example, a low-grade endometrial stromal sarcoma is treated with a hormonal therapy, with either anti-estrogen or an aromatase inhibitor. And then, of course, if it's the high grade, a lot of times they lose their hormone status. They may still continue it, but if it was a high grade endometrial stromal sarcoma, I would tend to treat with standard chemotherapy, doxorubicin, ifosfamide based chemotherapy, plus or minus ifosfamide. Now, the PCOMA is uniquely distinct in that they are very sensitive based on the pathway with the TSC mutation, that they're very sensitive to mTOR inhibitors. We recently had an FDA-approved drug, nab-sirolimus. In the past, we would use other oral mTOR inhibitors like sirolimus and everolimus. But now that we have the FDA approval of the nab-sirolimus, that tends to be our first choice. There are studies, and with PCOMAs, we also do want to know the estrogen status, because there are some studies showing responses with adding a aromatase inhibitor to either the mTOR inhibitor, or after they progress on an mTOR inhibitor, or even pazopanib, adding in an aromatase inhibitor, you can elicit responses. Also, the PCOMAs, I mean, I'm very aggressive with sending patients to the genetic counselor to look for germline mutations. In leiomyosarcoma, yes, but in PCOMA particularly, we would want to be looking for a germline mutation in those patients.
Treatments are totally different. I'm going to ask Dr. Pinto a question that he probably does know, that I just think I know, but I want to make sure that we're thinking about it. We see people with ESS, low grade, quite a bit. The molecular profile is totally different than a high grade ESS. They're actually two different cancers. And I'm not sure if one transforms into the other. They probably just start differently, but just kind of your thought of tumor evolution. This is not like a D. diff liposarcoma, or is it? Where it's a low grade and converts, or I think they're just two separate tumors. And I'm just, because at some point the ESS low grade lose their effectiveness with endocrine therapy, but they don't really turn into a high grade ESS. So kind of your thoughts.
No, I think that's a very pertinent question. It's a great question, because yes, these are tumors that are molecularly defined, so they're different. So they arise like they're they don't usually transform. Having said that, there are studies, not many, showing that tumors that morphologic, they're behaving like, so let's see, the tumor, like you mentioned, it started as a low-grade endometrial stromal sarcoma. That patient received anti-estrogen therapy, and we know these tumors, they can recur after many years. And all of a sudden, that tumor kind of behaves in a more aggressive fashion with higher recurrence rates and obstruction. And then we sample that, and morphologically, they look distinct. They look more like high-grade ESS. So there is some sort of thing of high-grade transformation of low-grade ESS, with a caveat, though, that if you sequence those tumors, they'll still retain the JASF1, the signatures that are unique from low-grade tumors. So they behave more aggressively. They can lose the expression of estrogen receptor, and even another one that we use, CD10. But they are still they are the low-grade that are behaving more aggressively. Let's put it like that. They're not really a different malignancy, if that makes sense.
That makes sense to me. As a treating oncologist, there's still really a low-grade ESS that become more aggressive. That's really what it is. They don't turn into a high-grade ESS per se, because those are a different molecular phenotype. But Dr. D'Amato, all of us at some point have to start using cytotoxic therapy if they start to behave that way. And just some general thoughts on your end.
Yeah, exactly. So, I try to avoid cytotoxic chemotherapy if the patient's eligible for non-cytotoxic chemotherapy. So, in a low-grade endometrial stromal sarcoma, for example, and a PEComa, for example, but both of these tumors actually can start to really become more aggressive clinically. And so I use that, what their doubling time is, their tumor burden, their previous response to treatments. And I've had to resort to chemotherapy in these situations where you have a low grade that's now behaving very aggressively. One could argue even biopsy showing now it's high grade. And then same situation with a PEComa where they've kind of exhausted their molecular targeted therapies and have to convert to a doxorubicin-based chemotherapy. And they can respond. You just want to try to avoid it if you can, but they do respond, both PEComas and high-grade endometrial stromal sarcomas to doxorubicin-based chemo. And even a second-line gemcitabine taxotere. I haven't had much experience with giving trabectedin to a non-leiomyosarcoma uterine sarcoma. But certainly in leiomyosarcoma, we have trabectedin.
Because we're talking about uterine sarcomas, the vast majority of uterine tumors, maybe excluding carcinomas, are fibroids. And a lot of times we spend a lot of time seeing things that are thought to be fibroids ending up not to be fibroids. So maybe Dr. D'Amato, you can kind of share your thoughts of, the pre-op evaluation of these things. I know we're on the sarcoma end, so just let you know, but it'd be just nice to see from the pathology standpoint, as well as how do you look at these specimens, and at what point in this whole journey of a patient do you kind of weigh in and say, oh, I got an endometrial biopsy, or do you just get the whole resected specimen? So maybe Dr. D'Amato?
Well, it's difficult because I'm not a gynecologist or a gynecologist oncologist. So we're getting these patients, after they've been diagnosed. I've been in practice for 20 plus years. I've yet to see a patient that come to me with just uterine fibroids and say, I think it's a sarcoma, so it's always coming to me after the fact. But there are studies showing the utility of certain prognostic factors, imaging by MRI, need for blood transfusion, the growth rate of the fibroid, that these are suspicious, and that at the age of the patient, these are all suspicious, and that you really need to be thinking that this could be a sarcoma. Unfortunately, that's not utilized in my experience as much as it can be. And so I think the sarcoma community, really needs to band together with the gynecology oncology community and really come up with distinct guidelines. And I think if we can come up with these prognostic guidelines or predictive models, that we could educate, the general gynecologists and gynecologist oncologists to say, look, we really want these to be evaluated beforehand. Biopsy would be would be preferred. I know that the gynecologist oncologists, they won't touch an ovary and biopsy it. And so I think they have the same principle as doing a uterine biopsy. They'll be fine with an endometrial biopsy, but you're just not capturing, the cells if it's from a leiomyo. You're not getting, unless you did like an I don't think they have an endoscopic ultrasound like they do, where you can get it actually from the wall. They're just doing the endometrial, but maybe they could come up with one where you can actually biopsy the uterine wall like you can a GIST with endoscopic ultrasound.
Absolutely. So the reason why it's great to have this discussion is pathology, you like to have more than just an FNA going into the uterus or that. So where do you see yourselves helping, in this dialogue of, pre-op management and or, if we start to make recommendations for biopsy of big masses, that's not generally what we do in the gynecology realm. We do it all the time in the extremity soft tissue retroperitoneal, but just get your thought from a pathology standpoint.
So yeah, unfortunately, like most of these cases are diagnosed by chance, by surprise, right? The patient, because fibroids, like you mentioned, are so common, right? More than a half of the women during menopause or postmenopausal women will have at least one fibroid. So you can't put every single, or like half of the population into some sort of pre-operative screening. I mean, you could, but I don't think the chances of being sarcoma are so low because of the rarity of the disease, whereas the fibroids are close to 60%. So that discrepancy makes the diagnosis challenging, like pre-op challenging. The rare scenarios that I see as a pathologist that we could have some information, and I'm not talking about imaging or clinical, that will differ, but like pathologically, sometimes when they do if the muscle, if the submucosal, if the smooth muscle tumor, it is submucosal, like right beneath the endometrial mucosa, when they do a nice curettage, you can get pieces of muscle. So they do what we call like a submucosal leiomyomectomy. So they just go with the curetting and take chunks of smooth muscle without removing the uterus, and we can diagnose sarcoma. And also, if the nodule is purely subserosal, so they're going to go with a hysteroscope and do a hysteroscopic just myomectomy. But those are not really, they're doing more for treatment, but they're not doing for like diagnostic purposes, right? So that's the issue. And so yeah, I'm not sure if we're ever gonna be able to, and like Dr. D'Amato said, I've read articles in terms of like MRIs, specific characteristic of those nodules, but how reliable, how reasonable it is to imaging everyone with an MRI, that's, I'm not so sure.
Thank you. Dr. Rosenberg, any additional thoughts?
The only other thoughts, I don't know why they couldn't stick a needle into the wall of the uterus coming from the endometrial cavity. And the other thing is develop imaging criteria to use to maybe do a liquid biopsy if there's significant suspicion of an aggressive neoplasm. And maybe get that genetic information to use to help make a diagnosis preoperatively.
There's groups thinking about it, working through it, so it's exciting, Well, first of all, I'd like to thank the University of Miami Sylvester Cancer Institute, and we spend our time today talking just about one location, the uterine, and we haven't barely scratched the surface here. So I do appreciate your time and expertise here. But as we go, I would ask each one of you, if you had one message that you wanted to share about uterine sarcoma, what would that be to our audience? I'll start with Gina.
So I would say that, uterine sarcoma is very, very heterogeneous. Even though it's from the uterus and it's a sarcoma, there's still multiple subtypes within those subtypes, and it's very important to have the pathology reviewed by an expert pathologist, both ideally, if your institution has it, both the sarcoma pathologist and the GYN pathologist, and that the patient be seen by a sarcoma expert or someone, even a oncologist that has expertise in sarcoma, because the treatments are vastly different, and there are a lot of treatment options, and there are a lot of clinical trials available, and your patient could be eligible for one of those.
Thank you. Dr. Rosenberg.
Yeah, I have to echo the same thing, that the most important thing for a patient, I think, is to be seen at a center of excellence for uterine sarcomas. That usually includes people with a high level of experience and expertise as in the multidisciplinary group in diagnosing and treating these tumors.
Appreciate that. Dr. Pinto.
I would agree with those comments. The only thing that I think pathology specific that I would add, to which we didn't have time to cover here today, was that in the GYN tract or in the GYN world, we have this biphasic tumor called carcinosarcoma, which, as we know, which is a carcinoma per se. And as we know, as we discussed at the beginning, carcinomas are way much more common than sarcomas. So specifically, if you're dealing with a small sample of the patient, or if the mass is mostly like located in the endometrial surface, before you make this very aggressive and rare diagnosis of sarcoma, consider that you might be looking at just the tip of the iceberg of a carcinosarcoma, which we're just looking at the sarcomatose component. And before you make the diagnosis, sample more. And if you roll out that component, then yes, you go into the differential, which is like expanding as we speak. I'm sure if we look in the literature right now, there's like 5 more molecularly defined rearranged sarcomas in the past month. So it's going to just get worse, like anything in pathology. But that's when the role of a multidisciplinary team with an oncologist, with a medical oncologist, with the gynecologic oncologist, and the pathologist come to play.
Well, you bring up a great point there, and we can spend another whole hour talking about mixed Müllerian tumors, or the carcinosarcomas that they're probably properly called now. And we didn't even talk about the adenosarcomas as well.
Right. Which is the same.
Because those are really sarcomas, and forget about the adenocarcinoma part there. But, fortunately, we're here for another day. We can come back and discuss a little bit more in the future about more of the ultra rare ones, because, as you said, there are some patients that are, all you biopsy is a sarcoma part, and you think it's a sarcoma and it's a carcinosarcoma, and they are treated differently. They're managed differently, and they're actually different diseases than a pure sarcoma of the uterus. So, boy, we have more questions than we started with here, Gina.
Well, this is what happens when we hang out with pathologists.
Well, I do appreciate the expertise, seriously, about this. I learned more today, again, from both of you, Dr. Pinto, Dr. Rosenberg, and Gina, how we should really continue to work together to kind of help women who are diagnosed with some form of uterine malignancy, and making sure that we get the right diagnosis and that we put them on the right treatment path. So we appreciate it. So thank you, guys.
Thank you.
Thank you. Thank you. This is great.
Thank you all for listening to us at SARC Talk, and we look forward to our next SARC Talk. And if you have any questions, please let us know. Appreciate it.
Thank you for listening to SARC Talk. Be sure to subscribe so you never miss an episode. To learn more about SARC, visit us at sarctrials.org. If you have questions or would like to suggest a topic, email us at sarctalk@sarctrials.org. SARC Talk is made possible through the generous support of Syrier Pharmaceuticals. Together, we can find a cure for all forms of sarcoma. This episode of SARC Talk is supported by funding from Audi Bioscience.